Medicaid program was signed into law nationally. This is not just Idaho. It was signed into law nationally in 1965. It's part of the Social Security Act. And the Children's Health Insurance Program, also known as CHIP, was signed into law in 1997. So a bit of a newer program. Medicaid is called what is known as an entitlement program, meaning that qualifying individuals are entitled to benefits through Medicaid. CHIP is not an entitlement program, and it is actually an optional program for states to administer. Most states, I think actually all states, do operate the Children's Health Insurance Program in addition to Medicaid for qualifying families based on income. Medicaid is a public health insurance program, again, available to certain populations, and we'll talk about eligibility a bit in the next slide. And we follow federal guidelines that establish the core requirements that we have to follow in the Medicaid program. And that can be everything from what services we can cover to how we can cover those services and how we must conduct oversight within the program. There are some flexibilities provided to states, and the saying that I like to abide by is that, one state Medicaid program, one state Medicaid program, meaning while there are certainly similarities in how they are run, there's also differences based on the state. So in Idaho, the following populations are eligible for Medicaid, and those are individuals with limited income, including adults, families, children, and pregnant women. And these are adults including the Medicaid expansion population, which are adults who are up to 138% of the federal poverty level. We also cover women who are diagnosed with breast or cervical cancer, individuals who are age 65 or older and who also meet income requirements, individuals who are blind or disabled, and that's using Social Security criteria. So they have a disability designation through Social Security. Children who are in state conservatorship or the foster care system with the state. And then we have other programs, which I will not get into in a lot of detail today, but we have other programs serving qualified individuals based on certain health conditions and income. And the example I have here is our Katie Beckett program, which serves children who have complex health needs, but who may actually have another insurance source, and Medicaid pays for very specific services to support them and their families. There are income requirements for Medicaid that are determined using federal poverty guidelines, also known as the federal poverty level, or FPL. And these are updated annually by the Federal Department of Health and Human Services, and then updated in our system accordingly. And in Idaho, the financial eligibility portion for Medicaid is determined by our Division of Welfare. And again, some colleagues on the phone today from the Division of Welfare who can speak more to that process. In Idaho, we have 3 distinct benefit plans for individuals served through Medicaid. The first is our basic plan. Also, this is also kind of carried over to the expansion population. So this is for folks who are in generally good health. They do not have disabilities or any sort of special health care needs. And this provides general health prevention and wellness benefits. So everything from a primary care visit to a hospital stay. We also provide behavioral health services and dental benefits as well for these individuals. Our enhanced plan is for individuals with more complex health needs and also physical disabilities, special health care needs, and those aged over 65. So on this plan, individuals are getting those basic plan benefits plus some developmental disability services. This also includes children's service coordination and other long-term services and support. So for example, nursing facility level of care would fall into the enhanced plan. And our next group is the Medicare-Medicaid coordinated plan. And this is for individuals who are eligible and enrolled in both Medicare and Medicaid. provides the enhanced plan benefits plus enrollment in a managed care plan, which helps to support coordination of care between Medicare and Medicaid, and also provides access to a care coordinator to facilitate that coordination. So this is a slightly outdated chart. We need to get our more updated SFY 2022 numbers in, but it just kind of gives you a general breakdown. I think the kind of break of population is pretty similar across years, but as you can see in this bar graph, the majority of individuals that we serve in Medicaid are children. We have a growing expansion population. So here in SFY 21, it was at around 100,000 participants. We are currently closer to 145,000 participants on Medicaid expansion. And then our basic adult and enhanced child, adult, and coordinated adult populations are smaller parts of the population, although they certainly do make up some of the cost due to their complex health needs in the program. Medicaid covers a variety of services. So again, physician visits, hospital stays. We cover dental for children and adults here in Idaho Medicaid, a full array of behavioral health services. We provide medical transportation and non-emergency medical transportation. Therapies, so physical, occupational, and speech therapies, pharmacy, and DME, and other supplies. We do cover institutional levels of care, so that may include a nursing facility or an intermediate care facility for those with intellectual and developmental disabilities and other long-term care supports. In Medicaid, we provide home and community-based services for individuals who are aged or who have a physical, intellectual, or developmental disability and reside in the community. And nationally, and here in Idaho, Medicaid is the largest payer of behavioral health and long-term care services. Again, this is a slightly outdated chart. We need to update it with our final 22 numbers, but I think the expenditures are similarly to the population breakout are similarly the same. This chart just shows a breakout of expenditures by service category. And as you can see, the majority of our expenditures go to our duals plans. So for individuals who are on Medicare and Medicaid, pharmacy, and inpatient hospital services are our top 3 areas of expenditures. So healthcare providers that want to bill for Idaho Medicaid are all enrolled as a provider first with a program before they can bill. So our fee-for-service providers enroll through Gainwell Technologies, and Gainwell is a vendor that we use that processes claims and processes provider enrollment files. And then any provider who's working directly with a managed care plan that we contract with would enroll through that vendor. We pay providers directly and have a written agreement or contract for all providers that we work with. We also have managed care here in Idaho Medicaid. And again, managed care, as probably many of you are aware, is when there is another entity really managing the administration of services and benefits. They are contracted with providers directly instead of the state and provide that care coordination element as well. So we have dental, behavioral health, those Medicare, Medicaid plans, non-emergency medical transportation, and vision, all through a managed care program here in Idaho Medicaid. Medicaid is jointly funded by federal and state funds. And so we get federal funds through what is called a Federal Medical Assistance Percentage, or FMAP, and that is determined by the federal government. The amount varies every year. It's updated on an annual basis, and it's based on the per capita income for the state. And so in Idaho right now, for every dollar spent on Medicaid services, approximately 76 cents of that dollar would come from the federal government, 24 cents of that dollar would come from state funds. And so it's always a federal state split. That ratio can also change based on the type of function. So for IT functions, it's a little bit different, but this is the 76/24 is kind of the general medical expenditure split that we have in Idaho currently. In our Idaho Medicaid budget, we have three main buckets of funding, and I'm just going to kind of really high level over the budget in this slide, but happy to answer questions later. But essentially, our first bucket of our budget is really focused on administration of the program. Um, so costs for administration, such as personnel and certain contracts, that only makes up 2% of our entire Medicaid budget. The rest is really for benefits, so payments to providers to render services, and that's for our traditional participants. So basically everyone except expansion participants, and then the last bucket is expansion. So I think this slide kind of in summary is that the majority of our budget goes directly to paying providers for service delivery. In this last slide, I'm also just kind of high level on this, but it is speaking to our Medicaid Management Information System, or our MMIS. And this is really the behind the scenes system here in Idaho Medicaid. Every state Medicaid program has an MMIS system, but it's the system that allows us to pay claims, to enroll providers, to house claims data, to house participant data, do data analytics, reporting. It also includes our pharmacy benefit administrator as well. So it's kind of all of those systems that exist behind the scenes that help us to administer the program. It's an incredibly important part of the program in helping us to effectively facilitate the administration of services and work with providers. And I think that is my brief overview of Idaho Medicaid. And I will see if there are any questions, or I think we have the Division of Welfare on this morning as well to answer any questions about eligibility. Okay. I think I see a hand up from Lori.
Are they serving lunch over there?
Sorry, I was trying to unmute myself. I have a few questions.
Sure.
So you say women with breast cancer can get Medicaid. What about men who get diagnosed with breast cancer? It happens occasionally. Can they get Medicaid?
So
if they meet the income guidelines?
So that's a great question, Lori. And we actually have our eligibility folks on the phone. I'm wondering if Tanya may know the answer to that. Otherwise, I might have to take that back to look at the eligibility requirements around that program. Tanya, do you know by chance if that's specific to women because it's breast and cervical cancer?
Yeah, I do not have the answer, unfortunately, for that. But I can reach out to our program manager, because that is a specialized unit who handles the BCC program, and I'll get that answer for you.
Yeah, it just feels like it would be discrimination if, women could be covered, but men. And then, so when you have the Medicaid that pays just the Medicare premium, is that under the Medi plan, or is that a separate program?
So yes, we pay the Medicare premiums for individuals who they could have a different Medicare plan, or they could have an aligned Medicare plan with us. But we do pay their Medicare premiums, Lori, directly through the department. And so it kind of depends on how the individual is signed up for a Medicare plan. And I'm not sure, Tanya, if you have anything to add to that. But it really kind of depends on how that individual comes in and if they have Medicare with one of our Medicaid plans or if it's different.
For the eligibility side, yes, we would look at all of those Medicare saving plans, including the buy-in for those premiums at the time that they actually apply for benefits. We also have an interface with Social Security Administration, so if they're active, we make those updates and make those changes as well.
Thank you. And then in Idaho, I know in some states, if a person has Medicaid and they want to see a provider who is out of network for Medicaid, they can't go see them. What is the rule in Idaho? Can their family members private pay for them to go see a specialist if they can't get into an Idaho Medicaid specialist in a timely manner?
So Lori, that's a great question. So typically, yes, we would want a participant to be seen by a provider that is enrolled in Idaho Medicaid. But we know that there are times when we don't have the right specialist in the whole state. We might have to refer someone out of state for a certain service. Or, certainly during the last few years, we've had some capacity challenges in the state. So we've had to refer individuals out of state to get care. And that's really facilitated with our clinical team to review that request. If the referring provider believes that the individual needs to see a specialist and knows that there's not a specialist in state that could provide that service. So that is facilitated with our team, and I'm happy to get you guys I'm not remembering the mailbox off the top of my head right now, but I'm happy to follow up with that contact information.
So if there's someone in state, but they can't be seen in a timely manner, will you guys expand within the state before you'd look outside of the state?
It really depends on the situation, Lori. So yes, we would look in state. And we are contracted with many providers in state, not all, but many. And you're right, depending on the situation, timeliness may be a factor. And so that's why it's really a conversation with our clinical team to look at the request. And if there is a solution in state or a provider in state that could see the individual in a timely manner, or if it's something that we just don't have the care for, or timeliness is a factor as well. So I don't think that it's one of those it depends answers. It really is case by case dependent. But we do cover providers who are out of our network through single case agreements.
I have a couple more questions if other people don't have them. How many people do you guys anticipate are going to lose their Medicaid after the public health emergency ends?
Tanya, do you want to take that one?
So we really don't have estimates. It would really be guessing. We know that we have individuals who we've had no contact with, and it could have been almost 3 years that we haven't had any contact with them. Press 1 to be connected to your meeting. So it really would be a guess. What we do know is we have a certain number of individuals who, in the past year, they have actually completed their reevaluation, and our system indicates that they are over income. And so that is the first group of individuals that we have put into the hopper to complete their reevaluation.
And then if patients are ready to discharge and they don't want to leave the hospital, right? But from our standpoint, they're medically stable. There is absolutely no reason. Is there a number so they can do a more timely appeal rather than waiting for an appeal, that we could give them a number to call to get a an answer of whether you guys are going to cover the stay.
And this is if they have Medicaid eligibility already established, Lori.
Correct.
Lori, I'll have to take that back because there are a number of steps in the appeal process. And typically we will, if there's a discharge, if there's a case where you're trying to discharge and are trying to find an appropriate placement for an individual, you know, you believe they are ready to discharge, but are having a challenging time finding that appropriate placement, we're also very happy to work with you guys on that case. You know, we know that there are times when admin days are needed as a placement is identified for an individual and to stabilize them post discharge. But typically, you know, our clinical team will work with you through that. So let me follow up with my clinical team to figure out what's the best number to reach them at.
Okay. And if you want to give that to since you have Carly's contact information, if you want to give that to her, then she can give it out to our team, if you don't mind, Carly. And I'm done with my questions.
Thanks, Lori. Great questions.
So I saw Laura Conlon had her hand up and then she took it down. Laura, do you still have a question? And then Bridget has her hand up.
This is Bridget. I'll go ahead and take it.
Okay.
A couple of questions I have. First off, is there the best number, best contact for people to call to see if they are eligible for Medicaid?
Our toll-free number,
Mm-hmm.
I can also send you a link, but it's 877-456-1233.
Perfect. And the other question I have, we have a lot of patients that have Medicaid and they need a new doctor or they need a resource for counselors and that. And beyond Google searching, is there a good place to find out who the whole list of people that accept Medicaid that might be taking patients? And then if it's a kiddo, do we need to send them to get a new Healthy Connections number, or can we provide resources to them and they can reach out?
So Bridget, it depends on the service. So you mentioned new doctor and then you also mentioned counseling. So I think it's if we need a new doctor, we're doing referrals. I think that needs to go through Healthy Connections. If it's on the behavioral health side, our contractor Optum manages all of the outpatient behavioral health services. So that would include outpatient, you know, counseling, therapy, and they would be able to provide a list of available providers in the service area.
I mean, would it be best for us as social workers, whatever, to call them, or should we send a patient to call Optum to ask who's available or taking patients?
I think there's coordination with both. Let me follow up on that and I'll get you our Optum contact information. So Optum has, they call them field care coordinators, and their role is really to coordinate services and help if it's parents or individuals identify available providers in their service area and help coordinate multiple services as well. And so I'll find out what that number is. I don't have it in front of me.
Not a problem. And that's kids and adults, is that correct?
Yes, Optum serves children and adults. Outpatient services only though at this time.
Sure. Okay, thank you.
Yep.
There's a couple questions in the chat. Shauna, when will Idaho start to end coverage for patients that were eligible for services due to COVID provisions?
Juliet, I'm assuming that you're pausing for me. Idaho actually began the unwinding process effective February 1st, and we have broken that up over the next 6 months. What happened for our customers who went into a protected status, we call this Medicaid protection in Idaho. It's our term. We have about 150,000 individuals, And so, you know, taking into consideration capacity, we are using 6 months. However, we are required to actually do a renewal for all of our individuals over the next year. So that's, as Juliet said, about 450,000 individuals.
Looks like you answered Karen's question. Can we get a resource list page for Medicaid services? And then is that the same answer for Shauna's next question is, do you have contact information?
Yep, I will
Okay.
send some contacts for Medicaid.
Okay.
Can you hear me?
Yep.
Hello?
Yep, we can hear you.
Yeah, we can hear you.
Great. My name is Virginia. I have a question. Does Medicaid offer any hearing aid coverage?
I believe in limited circumstances, we do. I have to check on the adult side. For children, I believe we would if a children had an auditory condition. I would have to check to remind myself on the adult side if we offer hearing aid coverage. I believe there are some benefit limits on the adult side. Happy to follow up.
Okay, awesome.
And maybe what would also be helpful when I send some follow-up contacts is a listing to our website that lists out the services that we do cover in more detail, our policies around coverage. Because as you guys can imagine, there's a lot of nuance to the different benefits and limitations on the services. So I will include that in the reference sheet that I send out.
Laura Conlon now has her hand up again. Go ahead, Laura.
Okay, thank you very much for sending us that information, the reference information. My question would be, your different levels for Medicaid have different benefits. So Healthy Connections has different benefits than other levels of Medicaid. Are you sending out general information? I know that, you know, LTC Medicaid doesn't have the same benefits as Healthy Connections and so forth, or so on and so forth.
So Laura, the Healthy Connections program is actually not a benefit package. It's a primary care program that's really aimed to support participants' connection to primary care providers. And so there's some coordination of care aspects to that program, but it's applicable really actually to all Medicaid participants. I think so the different plans that we offer that I covered, we have our basic plan and Medicaid expansion, enhanced for individuals with disabilities, and then our coordinated plan for individuals who are on Medicare and Medicaid. So is your question related to sending out information around the eligibility piece and the redeterminations for Medicaid eligibility, or is there another aspect to that?
Nope, I just thought it might be confusing if we had general information that didn't apply to one of the types of Medicaid is all. So if one benefit was covered by one type of Medicaid, but not covered by another type of Medicaid, I just wanted to know if there was going to be a distinction in that information.
So it depends. Are the orders written?
So we can add in some information to distinguish services that are different between the plans. What I'll also add is while Tanya's team, our Division of Self-Reliance or Division of Welfare, completes the financial eligibility portion for Medicaid eligibility, once an individual has Medicaid, They may, depending on their condition, may also go through a functional eligibility assessment. So those are, for example, for individuals with disabilities, have a functional eligibility assessment, and then they're eligible for additional services such as through the enhanced or coordinated plans. So we can, I'll try to include some information from our website so that you can have some more context on those pieces and what's available through those plans.
Thank you very much. You might have already reviewed it in the very beginning because I missed the first 10 minutes of this meeting. We had some workarounds that we were doing during COVID where we were able to submit a Medicaid application while the patient was still here in the hospital. As of May, when those pandemic assistance goes away, is that something that we'll be able to continue to do, or will we be limited? We'll be able to help them fill out their Medicaid application, but we will not be able to submit it any longer while they're still in the hospital?
You can submit, you can continue that process because I think that's on the eligibility side. I think that's an arrangement that we have with our long-term care unit. So that process will actually continue.
And this is Emilia. Just to add to that, yes, we did reach out separately, even when we were out of the COVID restriction, and we decided to continue the partnership on continue to submitting those applications with or without the COVID restrictions.
And is there any way we can work with you guys when it comes to A&D waivers? I know there's restrictions around setting up those A&D waivers, as you need a SIBR assessment and a couple other elements to be able to finalize a A&D waiver with a patient. But we do have a lot of barriers when the patient needs that, needs those components done, and facilities won't accept them without it. Is there anything that we can do, or is there any way we can work with you guys in order to be able to do more of that portion of the assessment or whatever it might be while they're still in-house so that we are able to discharge them to one of a Medicaid facility?
Laura, I just want to make sure I'm clear on the question. So the aged and disabled waiver, we do not use the SIBR for the aged and disabled. We use that for the developmental disabilities waiver. We do have another assessment tool that we have a team of nurses that completes the assessment for the aged and disabled waiver. So I'm happy to connect you with that team, or we can provide that contact information in our follow-up. But I just want to make sure I'm clear. You are speaking to the aged and physically disabled waiver, not the developmental disabilities waiver. Is that correct?
That is correct. And I did say SIBR, and that was a misspeak
It's okay.
on my hand.
There's so many assessments. There are many steps throughout the process. So I just want to make sure I'm clear in the follow-up. So yes, I can get you some contact information for our A&D team. But typically that is scheduled with one of our nurses, and they go through that process, but I can get a contact for you.
A lot of the times that nurse will not schedule that assessment portion while they're still in the hospital. And that kind of puts a hard stop on discharge planning because the facilities won't accept without that nurse assessment and knowing how many hours of support they'll get sometimes.
Gotcha.
So I didn't know if there was any way to help with that barrier.
I will bring that question back to our long-term care team, and we'll follow up.
All right, thank you so much.
Yeah.
Melody Eggersdorf has her hands up.
Okay. Well, yeah, thank you for your time.
Melody, go ahead.
All right, thank you.
Oh, can you hear me now? Okay.
Yep.
So part of it you answered with the adult and disability waiver, because that is an issue we have here as well, trying to get patients out. But I'm just kind of curious on a Medicaid application in general, what is your guys' time frame for turning those around once we get the applications to you?
So on average, it takes us about 10 days to do an application. And of course, there's different eligibility verification needs that could impact that. So for example, if it was a simple application where we were able to use our interfaces and get it turned around, that one's going to be processed fairly quickly. If we have to request level of cares or those types of things, that could extend the time frame. Does that answer your question? It's dependent.
Yeah, is there anything we can do on our side to speed that process up so patients aren't staying in the hospital longer than need be?
If you have cases in which you believe that there's a delay, you can escalate those and we will work with you. But what I'm hearing from the field, the hospitals are doing a really good job of filling out the application and getting the verification that we need. We're using our interfaces. It's just the exception that we may have to verify resources because it's outside of a MAGI Medicaid program that we need to approve. But I will take that back and look at some of the delays that we've been experiencing. But also, if you've got some examples, I could also set up a call and discuss that with you.
I don't have any examples right now. We've just had some in the past and then waiting to get the A&D waivers. So I was just curious in general how we could speed that process up because we've had patients in the house for 3 months while we're waiting on getting everything set up just to get them moved to facilities.
Okay, that one is outside of the eligibility, but I know that the division has been working on some of these smaller programs and how we can better serve our Idaho families. Both Juliet and I have been part of that, so we are looking at that.
Great, thank you.
Next question. So this guy, I'm going to go check, make sure, just double check that he doesn't have any oxygen for transportation. I'm assuming he doesn't because this is a new order. So do I get?
Okay, sounds good. Oh wait, there looks like there's a question in the chat. Let me check the chat here. From Amberly, we also have had patients that we may need a copy of the A&D waiver for the facilities. Is there a way we can get access to that?
And when they get home, they call Norco.
When you say a copy of the A&D waiver assessment, or because they have a plan of care following the assessment. I guess I'm not totally clear on your question.
A decision.
If they're covered or not through A&D. I don't think we can give you if they're covered. I'm trying to think through that, Tanya. So if an individual has Medicaid and they have A&D and the provider is trying to find out what coverage they have, I think that the provider could call us to confirm what type of coverage they have, but we wouldn't be sharing necessarily any additional information. I mean, it's very similar to like to insurance organization, like what, do you cover this? I think the provider would need to call into the department to confirm if they have A&D coverage. Or if they're covered by Medicaid generally too.
Laura, do you have another question or is that an old hand?
Nope, I have another question. So a lot of our facilities in this area recently, I'm talking about ALFs specifically, have been asking our Medicaid patients for buy-ups. I just wanted to ask, one, is this legal? And because it's not moral, is we doing anything to try to help with that situation? Because many of our patients can't, if they're already on Medicaid, they can't afford the additional buy-ups that a lot of the facilities are asking for on top of the Medicaid rate.
So these are long-term care facilities?
Yeah, assisted living facilities, and it's pretty common within the last 6 months-ish, and other leaders correct me if I'm wrong, but they
I
are
have not heard
asking
of this.
patients for buy-ups. Yeah, so they'll take the Medicaid rate and then they ask the patient or family for an additional $500,000, whatever it is, on top of that, and most of the people can't afford that. So
No, and there's no cost sharing for those services. And if you guys have specifics on entities that are offering the buy-ups, I would love to have that information.
I think it's for private rooms.
Is
no,
it
it's for
fair?
semi-privates too. I
Oh,
confirm that. Mhm.
okay. Sorry.
So it's like you can have this Medicaid bed, or if you want to buy up and pay out of pocket, you can get this.
Well, they'll say they have a Medicaid bed, and it'll be a semi-private bed, um, and they will speak to the patient or the family and then say, okay, you can have this semi-private Medicaid bed, but you will be responsible for paying $500 or $1,000 on top of the Medicaid rate.
I have not heard of that. But I would really like to dig into that further because no, they should not be charging or telling a patient that they have any sort of obligation to pay an additional amount.
Hopefully we
Tracy
can
can
connect.
Oh, the room's utility and food. Oh, the rough rate. Okay. Interesting. I've not heard of this buy-up term before. Um, I'll take it back to our long-term care team to see if they have some additional information. I'm afraid I can't hear the individual who's speaking. I can hear that they're speaking, but I can't hear them.
So we have a patient here that says she's followed by you, and I'm sure you knew it. She's in the hospital.
I know there's a question and slash comment out there, but we're having a hard time hearing you. Juliet, can you hear me?
Yep.
Okay. So it sounds like there was one more. Let's go to Brady. I think Brady put something in the chat here.
Hmm.
Oh, and
Yeah,
Rumley is trying to figure out how
MTM.
to make it so you can hear her. Okay.
So Brady, I'm happy to answer the MTM question. So I know there have been some MTM challenges, and yes, we are working through those. We actually we're entering into a new contract with MTM. They will continue to be our transportation vendor. But I think based on lessons learned and our experience in working with MTM and their experience working in Idaho, there will be some new offerings through this contract. So a new platform for providers to work in and some new, I'd say, provider and member outreach aspects to the contract that we will be working to bring online with MTM. If you have specific issues with MTM, I will include our MTM team's contact information when I follow up with some resources. So we actually have a team that does that deals with MTM or transportation related issues directly. So we'll work with you and then work with MTM to resolve. And so I'll include that if you have a specific issue that you would like to share with them. Yep, and we're happy to review those issues.
Also, Brady, Carly and I did have a meeting, just to add to Juliet's comments. We did have a meeting this morning with MTM. It was a pretty hard conversation between the both of us. So, and we've kind of come up with some forward-thinking solutions on how we can solve that internally and externally for our Medicaid patients that need transport. So more to come on that in next steps.
Great.
Okay, so room lady, did you figure out how we can hear you, or do you want to just type something in the chat? Maybe you can send an email to Carly, and then Carly can get that question
I think
over to.
she just
Oh,
shared
there it is.
another
Yeah.
buy-up issue with a voucher-like situation. Thanks for sharing.
Oh, okay.
I'll definitely take this to our long-term care team.
Yeah, and I think let's hold for like 30 seconds, see if there's any more hands up. Any more questions or last minute comments before we wrap this up? I'll hold for about 5 seconds. Perfect. Julia and team, thank you so much. Oh, here we go. That's how it always goes. Yes, we are recording this, correct?
Yes, we are recording.
Yeah. So I'm sure when we're done, they'll send that over to me, and I will send that out to your directors, and they can, between them and Carly, they can place it somewhere that's accessible. Okay, perfect. Julian and team, thank you so much for your time. I loved all the questions. A lot of
Great
hard
questions.
questions.
We have a lot of follow-up. So we'll send a bunch of contacts and information and links to other resources in response. But yeah, a lot of good questions today. And if there's anything additional that you guys think of, please don't hesitate to reach out.
Yeah, Juliet, I think, and I've gotten some IMs, private IMs about, I think there's been a lot of long-term care questions and thoughts and wondering, and we could talk about this offline, if we could get something like that set up in the next couple of weeks or so, just kind of do the same thing. I'd like to just kind of move forward with the series, and just as the teams start asking questions and we veer one way or another, then that can drive us to, you know, who do we talk to next at DHW, and get some of those answers and some education on that. That be fair?
Yeah, I'm
Cool.
happy to connect you guys with our long-term care team, since they are certainly more in the weeds and far more knowledgeable than I on some of those processes, and probably could could answer those questions a bit better than I quickly. So I will be definitely following up with them today on a bunch of these questions, and we'll talk to them about another conversation.
Yeah, if you just want to keep Carly and I in that email, we'll get it. Her and I will get that all set up just like we did this. So there's
Great.
not 100 emails going back and forth.
All
Cool.
right.
All right.
Thanks,
Thanks everyone
everyone.
for
Appreciate
participating.
your
We really
time.
appreciate your time.
Bye.
Have a good Friday.